Not yet. Yes. So I try to discuss some of the points as a physician I make in considering the strategy of watch and wait based on 3 real cases of mine. These patients were not my patients, but they came with an already made diagnosis and just wanted to ask me for their opinion. The first patient is a young female. She's actually a nurse. And since 2009, she had problems with platelets. And you can see her blood counts were not that dramatic, apart from a slightly raised platelet count. She was JAK2 mutated, and the diagnosis based on the bone marrow was essential thrombocythemia. The second patient is again a young male patient. He's an engineer, very active. He had no symptoms actually, apart from very slight dizziness. No splenomegaly. And again, if you look at his blood picture, look at his hemoglobin, and a slightly elevated platelet count. Again, he was JAK2 mutated, and again, he had a watch and wait strategy. And the third guy is a 50-year-old engineer as well. He had a newly made diagnosis of myelofibrosis. He had slight night sweating at the time when the diagnosis was made. And if again you look at the blood picture, it is not that dramatic. His hemoglobin was okay. He doesn't have any immature or bad blasts in his peripheral blood. And he did not have a big spleen. And again, he was JAK2 mutated. And as I said, this was a case of myelofibrosis. So across all the MPNs, for all the 3, the treatment suggested was watch and wait. So the question or the idea is, why do we do watch and wait? What is the rationale or the medical logic behind such a decision, especially knowing of all the progress, all the insights, all the new clinical trials, all the drugs that are available? I think whenever in life, whenever we make a treatment decision, I think it is always a balance between what is this treatment likely to give me and what is the cost I have to pay for this treatment, not in terms of money, but in terms of side effects, in terms of possible harm this treatment might cause me. When we look at the positive side, treatment goals, or what a treatment could give me, I always ask myself, could this treatment, if I give it to a patient, prolong his or her life? But considering patients with ET having an almost normal life expectancy, there is no drug, I think, in the world that I could give to make the life even longer. This is also, to a large extent, true for patients with PV. They have an almost normal life expectancy. Again, drugs are not likely to prolong life in the majority of patients. The situation is a little bit different in patients with MF. To prevent complications, we know the major complication for patients with PV and ET are thrombosis. But we don't have to forget that two-thirds of the thrombotic events patients with PV and ET get, they usually get them before we make the diagnosis. So in many of the patients, our intervention will not prevent an already thrombotic event that has occurred. Sure, my duty is to prevent another thrombotic event in that patient, or for a patient who had never had a thrombotic event, prevent him from getting that event. Another issue or a goal I have when I consider a treatment is this treatment likely to improve the quality of life of the patient? And if the patient is symptom-free and feeling well and very active, what drug is likely to further improve the quality of life of that patient? And finally, sure, it is always the issue of progression. And I always need to have data and evidence that the treatment I give will prevent progression, especially in cases of MPN. It is the idea of progressing to post-PV, post-ET myelofibrosis, or generally transforming to AML. But I will make it short, and you have heard the data in the previous sessions. Until now, we have no drug, no procedure that is likely to modify the rate of progression for PV, ET, or MF, apart from transplant, and even that is a quite complicated issue. And the other side, as I said, the risk of the treatment, and mainly the side effects. And maybe I'm just creating a kind of a lab cosmetics And this is, to be honest, one of the issues we love, because doctors love to do something. Sometimes the treatment is for the doctor rather than for the patient. And sometimes, and this is what we very often see in patients with MPN, that we are doing merely lab cosmetics. And as I said, on the contrary, maybe with my drug, I might cause a progression of the disease. We all know about radioactive phosphorus and the increased incidence of acute leukemia in patients with PV. And I think we have some guidelines that help us to guide our treatment decisions. And if you look at case A, this is the ET lady. Indeed, for patients with low risk, she was a young lady. She didn't have any thrombotic event. Observation is an option. For patient B, observation alone was not that right, because he was a case of PV with a very high hematocrit, and we have data that a hematocrit above 45% will increase thrombotic event. So he should have received aspirin and phlebotomy. And my question to you is maybe, and this could be discussed, do you consider phlebotomy a treatment, or is it a kind of watch and wait because it is a non-pharmacological intervention? And again, even for the most aggressive disease, myelofibrosis, still, if the patient is a low-risk patient, meaning a patient with a good prognosis, low risk of transforming to AML, no symptoms, observation again is an option. So it is justified to do observation if we really consider the risk of each individual patient. No, but the second question, is the treatment I make regarding watch and wait always the right treatment? And the answer is very clearly no. Doctors sometimes do mistakes, like everybody else. I'll just give you some of the common typical pitfalls that we encounter in everyday clinical practice. As I said, many physicians love to treat the lab, treating thrombocytosis. And even patients feel sometimes very comfortable, if they come with 700, 850,000 platelets, and I tell them we don't need to do anything because we have no evidence. And the MPN group has seen that adding hydroxycarbamide in patients with low risk will bring no evidence, no improvement at all, apart from side effects. It is really sometimes a long discussion, because even the patient sometimes likes to have the lab cosmetics and feels more comfortable if the counts are within the normal range, although we know that this will not bring anything in terms of survival or improvement in quality of life. On the other side, there are certain values we have to check and we have to keep at the certain level, like the hematocrit, for example, because of the very, very clear evidence we have that a hematocrit below 45 very much reduces the incidence of thrombotic events. And indeed, it is, at least in Germany, not always very strictly adhered to. And, they say, well, 49, 50 is not that bad. And I think, this is a chronic disease. MPN is a chronic disease, and the disease might change over time. And what we often see is that, once a patient has been labeled as a low-risk patient, over years, he will remain as a low-risk despite many, many things that might change. So I think a periodic assessment is very, very important. And as I said, sometimes the treatment decision is not really based on the data. It is just, a gut feeling of a physician or what the physician used to do all the time. And one of the most important things, and I think that is something we have realized very much in the last years, are symptoms. Symptoms, even sometimes patients don't realize that certain symptoms do have something to do with that disease, and that some of these symptoms over years have a very, very big negative impact on quality of life. And I think the work of Robin Messer has very much taught us that in patients with MF, we have so many non-specific symptoms that these symptoms are not related to our lab values, not related to anemia, to a low hemoglobin, but related to the cytokines. That's something we know now. And we always go with the patient through the MPN-10 and try to assess symptoms, and it's always a surprise to me that patients themselves get very much surprised that they don't realize that some of the symptoms they are suffering from for a long time are actually related or could be related to the disease. And symptoms are not just a problem with MF, but again, in patients with PV and ET. And if you just recall, my patient with ET, I didn't tell you anything about the symptoms because this was her major problem. She had a very, very bad history over years. She had several admissions to hospital because of severe constitutional symptoms, especially chills, fevers, attacks coming suddenly. Although her counts were not that dramatically bad, all the physicians said, you have a psychological problem, send her to a psychiatrist. She had social and family problems because, the family, she looked beautiful. She didn't look ill at all, but everybody thought that she was psychologically ill, and even at work, they thought she didn't want to work and she wanted to be sick and stuff like that. But we know now that these symptoms could occur even in patients with low-risk ET, because the low risk is for thrombosis and not for symptoms. And what I did in that case, I started her with aspirin to see if the microcircular dysregulation could be improved, but aspirin alone was not enough, and I just started her interferon alpha, and after 2 weeks she was sitting on the floor waiting to come in, and I just came across the door and she just jumped on me and hugged me, because after years all the symptoms just simply disappeared. So I think this is very, very important. Symptoms are very much often, even from us physicians, neglected, because we all love things to measure and love the things we could really easily see. The last point, what is the role of the patient when the physician tells the patient, we are going to do watch and wait? Have you got to accept that, or do you have an active role, like with any other kind of treatment? Because I think watch and wait is treatment. I think it is a teamwork. We have to make a clinical decision about treatment strategies together, especially in chronic diseases. I think we have to discuss the benefit and risk, as I told you, of every step we are taking, and we should do that together. Alternatives, as I said, are always very good to ask about. And as I said, periodic assessment should be done because things might change over time. And it is the duty of the patient to be very well educated regarding the symptoms he or she might suffer from, and has to pay and make the physician pay attention to that symptom. So my final slide is actually MPN, and this is, well, it is a challenge for us physicians, but it is so heterogeneous, and each patient is very, very individual. And I tell every patient, I need to know you. Give me some time to get a feeling of you as an individual person regarding your symptoms, regarding the risk of the disease, and then we could make together a weighing of risk and benefit, and then make together a treatment decision, even if it is watch and wait. And with that, I thank you very, very much. Thank you.